All right, welcome everyone to tonight's Woo You event with Dr. Elizabeth Muckley, and she's going to go over some glaucoma grand rounds. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'm so excited to introduce our speaker for tonight. Dr. Muckley is the director of the optometric services at Northeast Ohio Eye Surgeons in Kent, Ohio, where she concentrates in medical glaucoma and post-operative care of the anterior segment. She's a nationally recognized leader and speaker in the profession of optometry. Dr. Muckley was president of the Ohio Optometric Association in 2020 and subsequently served on the OOA board of directors for 9 years. She was instrumental in helping the passage of 3 Ohio laws, including scope of practice expansion. Dr. Muckley's passion for managing glaucoma led her to be the second female optometric clinician to be accepted into the Optometric Glaucoma Society in 2004. You were like 13 then, right?
Exactly.
So she is the author of the new glaucoma chapter in Luz Catania's, probably saying that wrong, aren't I? Edition of the primary care of the anterior segment textbook. She's a fellow of the American Academy of Optometry, where she previously served as on the nominating chair and research committees, as well as the governance task force. She's also on the AOA Research and Information Committee and the education chair of the East-West Eye Conference. Dr. Muckley has received many career awards for her service to the profession and patient care, most notably recognized in 2008 as the American Optometric Association's Young Optometrist of the Year, and in 2021 as the Ohio Optometrist of the Year. So thank you so much for sharing all of your knowledge with us tonight. Here are her financial disclosures, all of which have been mitigated. So I'll go ahead and have you take it away from here.
Thank you so much, Dr. Sorenzi, for hosting tonight. And I appreciate the wonderful introduction. And thank you to Dr. Wu and Woo You for inviting me back to speak to all of you tonight. I'm excited to talk to you all about some glaucoma cases. And we've got 3 cases to get through tonight. So we'll get started. The first case is a 63-year-old male referred for glaucoma evaluation. And this is a pretty typical case that many of you see every day in your practice. The pressures on the referral form were about 18 and 21 with a Tano pen, and there was not a time of day noted. And significance of that, obviously, is we kind of like to know when that pressure reading was, because pressures run a little higher in the morning for some patients, and it's kind of a good idea to get an idea of a couple of time points of pressure. And the refraction on the referral form showed some astigmatism. And I always like to know that as a doctor who gets referrals, because knowing a refraction tells me if someone has high myopia or high hyperopia, which can be risk factors for different types of glaucoma. And family history of glaucoma is important. There was none in this case. And medical history relevant for anxiety with Xanax PRN. And Goldman applanation tonometry yielded pressures of 26 and 28 at 9:13 in the morning. A little bit different from the 18 and 21 that was obtained at the other office from our referring optometrist. Symmetry was performed 583, 596, and slit lamp exam was fairly unremarkable for any other glaucoma findings, such as a K-spindle or pseudoexfoliation. Was some cataract starting, and of course gonioscopy is performed on glaucoma evaluations, and it was open 360 degrees with no other findings. So this is the presentation, the actual photographs of his optic nerves, and you can see the right optic nerve shows a really large CD and some inferior notching and bayoneting of the blood vessels. You can see that ciliary artery bending, which is a sign of cupping and excavation, and the lamina is very deep. And when you go over to the left side, this hazy view is because this patient has asteroid hyalosis. That's just not a bad photo, but that's actually the view from the asteroid. But you can see that their cup is, pretty good. There could be maybe a little bit of some changes down here, but for the most part, the isn't rule looks pretty good. So we, of course, obtain an OCT, and there are the OCT findings. Pretty consistent. You can see here the area of inferior thinning corresponding to that notching. And we're looking at overall symmetry between the two discs and cups, as well as the overall nerve fiber layer thickness and the changes there. We did run a visual field, and as expected, the left eye was pretty normal. Full findings, good reliability. We want our reliability indices to be, under 12% for false negatives and positives. And on the right eye, you can see the superior arc corresponds to that area of thinning in the inferior optic nerve. So this is pretty straightforward glaucoma case. So what's the diagnosis? Our diagnosis is really based on our visual fields. We have actual severe glaucoma in the right eye, and in the left eye, mild glaucoma, or possibly just ocular hypertension, depending on how you interpret the OCT and how you look at the optic nerve. So there's a little gray area there. You wouldn't be wrong to pick either or, based on what the OCT and the optic nerve look like. So you have your diagnosis. So proper coding is really important in staging glaucoma, because a lot of this helps dictate what your pressure goals will be, what they're going to be eligible for. So let's say their cataracts are ready to come out and you want to have them have a MIGS procedure. We have to be qualified for mild or moderate glaucoma for some of these procedures. So you want to be consistent, and some of the MIGS procedures don't qualify if they're severe. So proper coding is important. So mild glaucoma just means they have optic nerve findings consistent with glaucoma, but they don't have any visual field abnormalities on a white-on-white test, or they do have abnormalities, it's only detected on FDT or swab testing. Moderate glaucoma is optic nerve findings that can see, and then you have one hemifield affected with a visual field defect, and it can't be within 5 degrees of fixation. And severe glaucoma is either both hemifields have a visual field defect, or you have loss within 5 degrees of fixation in at least one hemifield. So even though that field down here doesn't look that impressive, it is, because it's threatening fixation, and that would be considered severe. So based on your diagnosis of ocular hypertension in the left eye, severe glaucoma in the right, what would you set as a target pressure? And you guys can put it in the chat room if you want to type in your answers to that, or just think what you would try to set a pressure goal based on the field and the way the optic nerve looks and the patient's age. So this is what I set. My target goal for typically severe glaucoma is to really try to keep the pressures down under 14. And even less in some cases if the visual field is very, very dense. In the left eye, we really want to try just to kind of knock the pressure down a little bit so that they never develop visual field deficits or changes in the structure of the optic nerve. And a lot of times, if you can get that pressure under 18, the likelihood of progressing is pretty low. You might even set a target goal in the left eye of 22. That wouldn't be wrong either. So, there is some wiggle room here, especially in an eye that doesn't show any visual field damage or any structural change. But we definitely still want to reduce that pressure, because we know one eye has already gone on to advanced loss and the other eye eventually will follow suit. So I would elect to treat the eye that just has the ocular hypertension in it as a preventative therapy. So we know in treating this patient, lowering pressure is the only proven method to treat glaucoma. And, when we set a goal, you have to base it on the following: your classification and staging of mild, moderate to severe glaucoma. And we also want to keep in mind the data from our evidence-based landmark studies like AEGIS. And AEGIS, patients in that study, if you recall, had unstable glaucoma, and they were randomized to ALT or trabeculectomy. And eyes in which 100% of visits over a 6-year period had a pressure of 18 or less showed very little visual field progression. And those patients with pressures of 15 showed half the progression of those with 18. And those with a pressure of 13 showed half the progression of 15. So that's kind of a good way to think about mild, moderate, and advanced glaucoma. 18, maybe a goal for mild. 15 might be good for moderate, and maybe 12 to 14 good for advanced. And then in our EMG study, we have to think about progression over a lifetime and risk of losing functional vision. And glaucoma progressed slower in the treated group. And for every millimeter of mercury that was lowered, we reduced progression by 10%. So, you want to follow these patients very closely and reset your target pressure if you can confirm progression or you note progression. And then also in EMG, don't forget pseudoexfoliation glaucoma doubled the risk of visual field loss. And that type of glaucoma can be very volatile with pressures kind of all over the board from visit to visit. So some of those pseudoexfoliation patients, you want to follow a little bit sooner and monitor a little closer for progression. Other factors to consider when determining a pressure goal is the patient's age. How aggressive are you going to be on a person who is 90 years old that you just diagnosed with glaucoma versus someone who's 45? Race. We certainly know certain ethnicities and races are more likely to have deeper disease and significant progression. Life expectancy. Socioeconomic factors. Can patients afford their medications? Can they help get their drops in themselves? What are their living arrangements? Can they follow instructions? And what's their hygiene? Because if you're talking about surgical intervention in some of these MIGS procedures, you don't want to get infections. What's the status of their other eye? Are they a one-eyed patient versus a patient who's binocular? You might be a little more aggressive in really watching those monocular patients for progression and setting a more aggressive pressure goal. So initiating treatment, we have a discussion with patients that, when I tell them that they're diagnosed with glaucoma, how we treat glaucoma. I mentioned all three things. We talk about pharmacologic agents, we talk about surgical intervention like SLT, and we even talk about intracameral implants like Brista. And you want to educate the patient as much as possible because you want to get their buy-in and their input on treatment so they'll be more compliant. If they're terrified of laser surgery, then that suggesting that and pushing them into that may not be something that they'll want to do, and they may never come back to your office to see you again and you've scared them. They might be terrified of side effects of drugs and don't want to be on drugs but want a laser surgery. So it's really a good idea to kind of talk to your patient, kind of feel out how they perceive treatment and what they might be most comfortable with. All right, so what would you recommend? Lower pressure, and you can type that into the chat as well. We discussed all three options, as I mentioned, and the patient chose to start off with drops and pharmacologic intervention. So we started 0.01% bimatoprost or Lumigan, and I am very funny about telling patients to take drops at bedtime because bedtime is different for everybody. Some people go to bed at 2 a.m. and some people go to bed at 8 p.m. And we really want prostaglandins to work and kind of cut that early morning pressure spike between 4 and 8 a.m. So I try to tell patients to take their prostaglandin after 5 p.m., for sure before 10 p.m., or it may not be quite as effective in reaching that early morning pressure spike. And then we follow up in 1 month from that just to kind of see how they're doing, make sure the pressure's gone down and they're not having any side effects or problems with the drop. At their 1 month follow-up, their pressure was reduced to 17 and 16, which is good. Are we happy with this based off of our visual field? And in my opinion, with the amount of damage in that right eye, a pressure of 14 is really where we want to go. What are our next steps? And we can certainly, rediscuss all that. I talk about SLT as an adjunct. We could instill timolol in the morning in just the right eye. And we could also change from Lumigan to Rocklatan and see if that wouldn't help lower the pressure just a few more points. We're pretty happy with the left eye. We don't really need to do anything there. So based on this, our patient did elect to undergo SLT in the right eye. And after 6 weeks post SLT, the pressure reduced to 12. And you do want to wait about 4 to 6 weeks post SLT to really kind of get an idea of where their pressure is settling out. Some people have an early response after SLT where the pressure will go down in about 2 weeks. Others take a little longer, and sometimes, up to 8 to even 12 weeks. So you do want to make sure that, you give this time for those macrophages to work and for the inflammatory process to work to help, get the most effectiveness from the laser. And then I recommended following up in 4 months for a pressure check to make sure that they're holding. This brings about the question as to, well, when do we, restart and retest visual fields in OCT? So, most people do annually to monitor progression and establish a rate of progression. You could do a repeat in 6 months on the field. That would be very reasonable because we really don't know if this patient is going to be quicker or slower. And, there's no right answer in this. There's no cookbook for glaucoma. So you just don't want to not do it. Sooner is better than later. So once you kind of get a feel that this pressure is holding steady and the patient's comfortable in 4 months, then you can kind of decide, am I going to bring them back in another 4 months and run the field, or am I going to wait a little bit longer? I also like to know, I told you mentioned family history. If siblings have glaucoma or parents, I always like to ask if there was blindness in the family from their glaucoma, because that also tells me how aggressive the gene is in this family. And if I have a sibling or a parent that lost vision from glaucoma, that's also going to be a red flag to really watch for progression quicker in this patient than someone who could be a slow progressor. So very quickly, we'll talk real quick about visual field progression. The thing that you need to know the most about is rates of mean deviation change vary from 0 to -2 decibels per year. And rapid progression is approximately -1.5 to -2 decibels a year. So if you're seeing that type of change in your visual field, that's a red flag for rapid progression if it's a reliable field. And keep in mind that with pharmacologic intervention or lowering the pressure, most patients don't progress at a rate that would lead to functional impairment. But sometimes, despite our best efforts and even lowering pressure 20-30%, 3 to 17% of patients can continue to lose vision. So it's always really important to set the stage with these new glaucoma patients that you educated them and said, hey, I'm lowering your pressure. This disease is a lifetime disease. And sometimes, even if we lower the pressure and we think we're at a good goal, it's like other neurodegenerative diseases like Parkinson's or ALS, things can progress. And we want to be able to get that right away. And if we see progression, our next step will be to lower the pressure further and intervene so that we don't lose vision. This is really helpful for patients to understand how a silent disease can cause blindness, and most don't have any symptoms, even with large field defects. So, it helps to show the field, show the OCT. For OCT, progression is usually a difference of 7 microns of thinning in the superior and inferior quadrants between scans, or a difference of 4 to 5 microns in overall thinning in average nerve fiber layer differences, as long as they don't have other disease like diabetes or macular or something else creating nerve fiber layer dropout. So you want to look to make sure the nerve fiber layer defect isn't widening, isn't deepening, and not getting a new defect when you're analyzing the OCT. And then once a patient really has advanced thinning overall, hit kind of the floor. And when you hit the floor, the OCTs are not usually very helpful anymore. And you're better to continue to monitor patients with fields and even throwing in a 10-2 versus a 24-2 every once in a while to try to, monitor the progression that way. So you need to kind of obtain enough visual fields initially to get good reliability and repeatability. And then once you kind of know if this patient is a slow progressor or not progressing at all, then usually once a year is pretty good. But if they've got advanced disease, then every 6 months, and sometimes every 4 or 5 if they're hanging on by what I call an optic nerve thread and you're in danger of snuffing out the nerve. So, if you have these severe cases, you really need to run those visual fields more frequently, look for change over time. And with imaging, again, every 6 to 12 months, depending on if mild or moderate, and you're evaluating both the macular and the optic nerve tomography. And again, if you have advanced disease, OCT may not be quite as helpful. So the bottom line is if you see progression, lower the pressure goal and change your treatment. And if the pressure is not holding at your established goal, change it or add treatment. And sometimes it's a really good tip that when you diagnose somebody with glaucoma, in their diagnosis, you write, kind of what their pre-treatment pressure was and what your tentative goal is. That will help you not forget. And sometimes it's really easy to have a low tension glaucoma patient come in and you see that their pressure is 16 and you think, oh, this is great. And then you realize, oh my gosh, that was their pre-treatment pressures. Really their goal is 10 or 11. So you can lose track of this over time if you're not careful. So glaucoma flow sheets, a lot of the EHR systems help monitor that creep up, and you just want to be aware of that. All right, case 2. A little more difficult, a little different. Background on this is a 21-year-old Black male Kent State football player. I practice near Kent State University here in Ohio. We get a lot of Kent State athletes coming in, and he was hit in the right eye by one of those rubber exercise bands during a practice workout. He came in right after it happened, about 2 hours later, with pain, swelling of the eyelid, blurred vision. Vision in the right eye where he was hit was 2200, 20/20 in the left, and his pupil showed poor reactivity. And then there's his presentation. I think all of you can see the hyphema has not layered yet, but what's the first thing you must rule out? And if you want, you can put the answer in chat. Even more important than worrying about pressure and worrying about this hyphema, when you have trauma, the most important thing you must rule out, first thing, is open globe. So that's one thing you got to do first and foremost, is make sure that we do not have an open globe, because if they have an open globe, they're headed right to surgery. That needs repaired stat. That is an emergency. And open globes tend to have a ton of bullous, chemosis, subcongenes 360. Might have a Seidel sign. They could have a shallow anterior chamber. You could even have iris coming up through where the laceration is. You would have a peaked pupil and very much limitation of OMs. Sometimes they can be very difficult to see. So if you're not, sure and things are questionable, sometimes you do have to get a CT scan. For this patient, you could see he didn't have, 4+ bullous, subcongene. We were able to really look around. There was no sign of an open globe. He did have some Decime folds starting in the cornea. His iris was intact from what we could see, except at the inferior portion, it was hard to tell. There did not appear to be any iridodialysis. 3 to 4+ RBCs in the anterior chamber, had not layered yet. His lens appeared to be in place, and his pressure in that eye was 32 compared to the eye that was 15. So I get asked this all the time. So do we dilate patients with the hyphema, and do we gonio patients with the hyphema? I want you to think about that. And the answer is, please dilate trauma patients. We do want to try to make sure that we don't have retinal detachments or commotio retinae or choroidal rupture. But I do think if you can try to dilate those patients and make sure that you get a view, you want to try to do that. If you can't do it that day, then bring them back the next day. You definitely have to obviously check the retina. Gonioscopy on a patient like this, we definitely want to delay. Do not want to do gonioscopy, when they're in the middle of an active hyphema, because you can cause a rebleed or continue to cause the blood to continue until they have time to heal. We typically don't recommend gonioscopy until they're about a month healed from their trauma. And when you do, you want to use a 4-mirror. You don't want to do a 3-mirror and press because that can sometimes cause a rebleed as well. So taking a look at the fundus, it was a poor view of the retina due to the media, but no obvious detachment, commotio, or rupture, and he had a really good red reflex. So what is our official diagnosis? So we have a traumatic hyphema, and we have a secondary acute glaucoma, obviously because the pressure's up to 32. So hyphemas are really due to a lot of times a tear in the face of the ciliary body or iris sphincter tears. Force trauma is very much the main reason for hyphemas. And the arterial circle that is in that area is very easy to bleed with that blunt force impact. And when you have a hyphema or blunt force trauma, there's a very high risk of angle recession. And that is something that you have to investigate after they've healed and really educate them on over their lifetime. So with angle recession, most individuals will develop glaucoma if they have angle recession that encompasses about 180 degrees of the angle. So you can see here in the picture, angle recession is a widening of the ciliary body. The ciliary body shouldn't be this wide. This is more normal ciliary body all the way over to that left side. And you can see how it widens out towards those white arrows. And that definitely is a recession. And you want to see how far that widening occurs. Because if it's quite a bit of the drain, you know that drain over time is going to eventually malfunction and their pressure is going to go up. So, for their lifetime, they might not have glaucoma today, tomorrow, 5 years from now, but 20 years, that drain is eventually going to malfunction and it will wind up probably with some degree of glaucoma and that they need to be watched. So we do 4 weeks after trauma and do gonioscopy then. All right, so how do we manage this patient and are there any special considerations? I want you to think about who this patient is, the history, and are there anything special that we have to keep in mind when we're thinking hyphema? So the one thing we want to always ask is, are they on any other medications that can thin the blood? There's non-steroidal anti-inflammatories. He is an athlete, so they take Advil a lot. You want to ask about that. Coumadin, you want to make sure that they're not on like ginkgo biloba or a lot of vitamin E, anything that can affect clotting. Then it's really critical to note that in Black or Mediterranean patients, you must ask about sickle cell trait and sickle disease. That is something that a lot of people forget to do. It's not always on our radar. It's critical in this patient demographic because it can really cause severe outcomes with hyphemas. So sickle cell is a concern because the red blood cells can sickle in the anterior chamber, and this will clog the trabecular meshwork and perpetuate the hypoxia, which will perpetuate the sickling, which will perpetuate the clogging, and so forth. And the pressures can stay elevated quite a bit. And then when you're in a hypoxic situation, they're more at risk for developing a central retinal artery occlusion or even an anterior ischemic optic neuropathy. And this can happen even at lower pressures. So even like a pressure of 24, which may not be harmful, someone who does not have sickling, has a hyphema, could be harmful to somebody who has sickle cell disease or sickle trait. So you definitely have to keep this in mind. And this can occur with all phenotypes of sickle disease, whether it's sickle trait, sickle disease, or sickle cell anemia. So this is important to note. So it wasn't really until 2006 where there's now universal newborn screening for sickle cell disease. So if a patient really was born prior to 2006, they may or may not have been screened as a newborn for sickle disease. So if the pressure is elevated with hyphema, you might want to order a sickle cell prep, which is a really easy screener for sickle cell. And if it comes back positive, well, then you'll want to order the hemoglobin electrophoresis. But if it comes back positive, then you kind of know we could be in trouble here and you have to, keep that in mind. It can take some time to get the results, but keep in mind that about 10% of African Americans do carry the sickle hemoglobin gene. So I did order a sickle screening on this patient, and thankfully it came back negative. And so our typical therapy for hyphemas is we do like to cycloplegia. We do start a steroid about every 2 hours to help with the inflammation. And obviously we want to lower the eye pressure, and that pressure is going to continue to go up as the blood starts to go through the trabecular meshwork. And are there any glaucoma medications may not be our first choice in this type of situation? One, you can put that also in the chat what you think would not be a good initial glaucoma medication to treat. So our best choice is beta blockers and alpha agonists. We want to try to avoid a prostaglandin because it can increase inflammation, and it may not work quite as effectively when there's inflammatory glaucoma happening. We also want to keep in mind that if this patient was suspected of having sickle disease, you definitely want to avoid oral and topical carbonic anhydrase inhibitors, because CAIs can increase the pH of the anterior chamber and again creates acidosis and causes sickling to be promoted. So, in a patient without sickle disease, you could definitely do dorzolamide timolol. You could do, dorzolamide brimonidine. If you're suspecting sickle disease, do not do carbonic anhydrase inhibitor. So I started combination brimonidine timolol twice a day. It's a really good punch for pressures in the 30s. Those combination meds work very, very nicely. So, you bring the patient back and monitor them. And if the topical and oral therapy are failing, then you may have to surgically evacuate the blood. And you don't want to keep the blood in there, not layering if they're continuing to bleed, because if they get endothelial blood staining, that can permanently affect vision. And also, too, if the pressure is greater than 60 for more than 48 hours, obviously you want to get that blood out, because now we're going to start to have some compromise in the optic nerve. And if they do have sickle disease, instead of waiting until the pressure is 60 for more than 48 hours, if their pressure is kind of going in the 30s, that might be a time to consider doing a blood evacuation. So some supportive treatment that we also recommend for hyphema is an eye shield at all times during the day and at night. You don't want the patient accidentally rubbing their eye. Strict bed rest has not been shown to be beneficial, but we want them on mild activity. So I say, just be a couch potato. You can get up to go to the bathroom. You can get up to, get some snacks and move around, but I don't want you, being super active and having a lot of, activity, because we don't want to rebleed. We want the blood to cease. Head elevation is very important, usually about 30 to 45 degrees. It does help the blood to layer and keep it inferior. And remember, inferior too is the widest area of the angle. So we definitely want that blood to kind of start draining out of there. And it'll help keep the pupil unobscured and decrease our risk of the corneal blood staining. And again, remind the patients not to take any aspirin or non-steroidal anti-inflammatories so that they don't rebleed. So the going home instructions for this patient was atropine daily, steroids every 2 hours, Combigan twice a day, eye shield, bed rest, sleep propped up. And then, of course, we want to give our D warnings, because we can't get a great view of the retina yet, and we want to make sure that the patient understands what to watch for over the next couple of days. Then also give them a heads up about the future risk of glaucoma if angle recession is present, and the importance of us making sure that they do follow up for their 1-month visit so that we can do gonioscopy. So the next day we brought him back. The hyphema was layering much better. We're now at about a 25% hyphema, much less injection. Corneal edema had improved, and the pressure was down to 24. And thankfully, the sickle prep was negative. So this is a good outcome so far. And it does not appear that there was any iridodialysis or tears. So you'll continue to monitor every few days until the hyphema resolves. And you adjust the medication as the condition improves. So as things start improving and the pressure starts staying down and the blood starts going away, you can take them off their, prednisone. You can take them down and taper off their Combigan. Obviously, the atropine is one of the first things we'll kind of quit, because nobody likes to be on that drug, and it can last a few days anyway. So we'll re-examine the fundus as soon as you get a good view of the retina. We did that at this day because we really had a really good view. He's kind of mid-dilated. We were able to really assess for any holes, tears, or commotio in the retina. Then again, gonio 4 to 6 weeks to look for angle recession. If angle recession is present, then you must get a baseline OCT and visual field. If you baseline patients, you always know if something's changing. And you do need to monitor about every 6 months for change over time. Then significant education is required, especially these young athletes. When people are young, they think they're invincible, and they're going to forget that they had this accident and know that when they're 45, all of a sudden could come back and them. So you really have to make sure that they understand and you document in that chart that you educated the patient on their lifetime risk of angle recession glaucoma and advise them to have a yearly eye exam for the rest of their life, as this could potentially be more of a problem 20, 30 years from now. All right, so we have time for one more case. All right, this patient is a 73-year-old white female, and she reports on a Saturday morning for a comprehensive eye exam because the vision in her right eye has been blurry, and she had COVID 4 months ago. And she's complaining of a dull ache behind the eye a couple times a week. It doesn't last very long, and it kind of feels like a pressure back behind the eye. She does not have any floaters. She notes that she's been having a little bit of some flashes like looking at stars. Her medical history is just remarkable for thyroid disease, hypertension, she's a little hard of hearing, and arthritis. Her systemic medications are the levothyroxine, and she's on losartan for blood pressure. Her entry vision was 20/50, and she did pinhole to 20/30 minus in that right eye. Left eye was 20/30 plus. Her present glasses are mildly to moderately hyperopic, and her right pupil minimally reacted and was about 5 millimeters fixed. Her left eye had 2+ reactivity and was 3 millimeters round. And her pressures were 61. And we checked it numerous times in the right eye and 19/21 in the left. All right, so slit lamp exam. Her cornea had some anterior basement membrane changes to it. Her anterior chamber was extremely shallow, but it was quiet. Her iris looked pretty normal, and she had about 1 to 2+ nuclear sclerosis. In the left eye, also some basement membrane changes. Her anterior chamber was also shallow and quiet. Iris appeared normal, lens 1 to 2+ NS. So we always gonio patients, of course, right? When we're looking at glaucoma, you have to gonio patients. You get paid for this. It's part of helping us diagnose what type of glaucoma we have. You have to gonio patients. Gonioscopy in that right eye showed basically Schwabe's line. We were closed 360 with no structure seen, and there was evidence of peripheral anterior synechia on indentation. And so what that looks like is in the picture over on the right. So on the left, you can see there's no structures seen whatsoever. We're just seeing basically iris here. But when you push, you now can open it up, and then you're opening up the angle. But do you see how it's tented up? How you get these tent-like projections up into Schwabe's line here? That is peripheral anterior synechiae. They look like tented protrusions up into the edge there. And then her other eye, I need to make sure I mention that, showed trabecular meshwork inferior with Schwabe's line nasal, temporal, and superior visible. So we do a quick undilated look. I think that's really important that we always look at the optic nerve. And in the right eye, you can definitely see that we've got about a 0.7 to 0.75 cup, very thin inferior rim. We have in the left eye a pretty normal CD ratio. We've got maybe a 0.4 to 5, but you can tell that we have healthy rim tissue. I don't see any notching. I don't see any excavation, bayoneting. We're following the isn't rule. We did have a vitreous detachment in the right, and the retinal vessels were normal. The macula showed no subretinal fluid, hemorrhage, or exudates. So everything pretty much is pointing towards chronic angle closure glaucoma in the right eye and angle closure suspect in the left. So let's talk about what those diagnoses mean. I called it indeterminate in the right eye because we haven't gotten a visual field yet. In order to stage the glaucoma, we need to know if, we're missing any field defect. So in the beginning, we just call it indeterminate until we can run a field and stage it. And then the left eye, yes, her angle was narrow. It is occludable, but it hadn't caused the glaucoma at this point yet. So she's basically got narrow angles there. So meeting our definition, narrow angles that are occludable show less than trabecular meshwork seen in 2 quadrants. It's usually not any peripheral anterior synechia, and there's no glaucomatous cupping or visual field defect. Those are the patients we typically see on routine exam that we screen for and then refer for an LPI prophylactically. Angle closure is when you have the above findings, but then you start to see peripheral anterior synechia, and then the pressure is elevated. Angle closure glaucoma is where you have all the above findings, but now you have glaucomatous atrophy and optic nerve changes. Remember, if this patient had a pressure of 60 but had a normal appearing optic nerve and a cup of 0.3, we would have called her angle closure. She wouldn't have had glaucoma because we don't have glaucomatous defects. There is a little bit of some nuances there in how we're really diagnosing these patients and getting them the right diagnosis, because this will follow them the rest of their life. Okay, so what do you do next? It's Saturday morning. You're the one in the office. All the ophthalmology practices are closed. Panic? I know some of you might. I used to panic. Do you refer for an LPI? Do you call that ophthalmologist up and make sure that they're 60 miles away and drag them into the office? Or maybe if you're lucky enough to be in one of the 10 states that now have laser privileges, maybe you do your own LPI. Do you order a visual field or OCT? All right, so let's back down and not panic when we see a pressure of 60. Remember, this has kind of been going on and off for a while. They've been in kind of this intermittent angle closure, probably for months. And our main job to try to make sure that a PI can be performed safely is to try to pharmacologically break the attack and lower pressure. It makes the PI much easier to perform. And those of you that are in states doing, LPIs, you know this because, if you're going to do a PI on a pressure of 60, it's like a geyser that goes through. And it is not easy to do those LPIs on pressures that high. So LPI does not have to happen right then. You really want to try to bringing it down. And if you start to kind of bring things down, oftentimes the ophthalmologist might say this can wait until Monday because they've been living with it for a little while, and you're going to get them on some meds to tie them over the weekend, and first thing Monday morning they can have this done. And then remember, we need to protect the other eye as well. So we're going to start a beta blocker, alpha agonist. We're going to do pilocarpine and topical carbonic anhydrase inhibitor drops, spacing them out about 10 minutes apart. Put one drop in from a class of meds, wait, next drop, and you keep going. And you can do this 2 or 3 times and go through the cycle. You can give a prostaglandin, but it may not be quite as effective over a pressure of 55. But I'll tell you that if this, when this patient's in my office, I added the Lumigan. We had a sample of it in the office. I'm going to add it. It's not going to hurt anything, and hopefully it'll help. And once the pressure starts coming down a little bit lower, even at 40, it might bring it down a little more. So definitely go ahead and just still try to add prostaglandin. And give them some topical prednisone because that will help with the inflammation as well in that cycle of drop. I like to also give 2 250 milligram tablets of oral acetazolamide in the office, as long as nothing is contraindicated like kidney disease or a sulfa allergy or anything like that. And you want to check the pressure then in about 40 minutes and see how far it's come down. I really like to have a stat kit already prepared in the office that I call it my angle closure kit. And you have all classes of sample drops in there, plus a bottle of oral acetazolamide. And you really want to do the non-extended release acetazolamide. You really want to do 500 milligrams right then, not the extended release, so it works right away. So after a bit, the pressure started coming down. I could see that it was working. We wanted to send the patient home with all the topical drops, plus doing 500 milligrams of the CIAs through the weekend. And remember to warn your patients that they're going to have some tingling of their fingers and toes. They might have a metallic taste in their mouth, and they might have an increased frequency of urination on acetazolamide. And then we schedule the patient for Monday morning for an LPI, unless you are in a state where you can do it. And then if the pressure is starting to come down, you can perform the LPI right then and there. And then the other thing consider we want to do is for the other eye, and I don't know if I have it in here. Oh, I do. You want to put the patient on pilocarpine 4 times a day in the left eye to prevent that attack happening in that eye. So don't forget the eye that is the suspect. Still get them on pilo, pull that iris away from the drain until they can have the LPI. And if you're in a state where you can do it, you could have done the LPI on the left eye right then and there. Okay, so the LPI was successfully performed on Monday. Now what? Okay, so you're going to bring the patient back the next day on Tuesday, and you're going to measure the pressure. And the patient was still on some combination topical beta blocker, alpha agonist, and the prostaglandin. Pressure was 11 in the right eye and 13 in the left the next day. All right, so now we can start to stage the glaucoma and evaluate the damage and see if we need further treatment or what we want to do and how are we going to manage these drops. So we want to recheck the gonioscopy. You want to make sure the angle's opened up a little bit. You want to check the patency of the LPI, and it can close up to a month after an iridotomy. So, keep checking that. And once you're a month out, the likelihood of closing would be pretty low. This is her baseline OCT, and we can see there is significant damage in that right eye and nerve fiber layer thinning, paired obviously to nerve fiber layer in the left eye. And then this is our field. So we can see that the left eye is completely normal, which correlates and makes sense with the normal, OCT. But you can see we have severe superior and inferior arcuate defects that absolutely correspond to the areas of thinning in that OCT in the right eye. So our diagnosis is severe angle closure glaucoma in the right eye. We have angle closure, suspect and narrow angle in the left without evidence of glaucoma. So our next step is now we have to decide how we're going to manage this right eye. With that amount of damage, I do believe that the pressure needed to be, again, down around 12 to 14 going forward. Left eye, it's fine. There's no damage. Pressure can be, normal, 22 or lower. So there's really nothing further to do with that left eye at this point except monitor it. The patient, we advise her to stay on the combo medicine, the brimonidine, timolol, twice a day in the right eye. And we were hoping that that would kind of hold her pressure. And we tried stopping the prostaglandin and no meds in the left. And then we brought her back and her pressure did stay down. And that was really all she needed to keep the pressure under good control, and monitored her every 4 to 6 months. And actually, she came in this afternoon. It was really funny because I knew I was giving this lecture today. And she actually came in today, and it's been about 8 months since I've seen her. And her pressure today was hovering down around 11 and in her right eye, and there was no sign of any progression or changes. So, she's been very stable now. The medicine in the right eye has helped her. We could do a clear lens extraction. Let's say that the pressure didn't come down post LPI and it wasn't really responding to the drops, and maybe plateau iris was a major issue. The next step would be then to just take out her lens. And usually once you do a clear lens extraction like that, the pressure does come down. But because we were able to lower the pressure with an iridotomy and her medications, we did not need to proceed with the clear lens extraction.